Good afternoon, everyone, and welcome to our May webinar at the UCLA Center for Health Policy Research. My name is AJ Scheitler, and I'm the Director of Stakeholder Relations here at the Center. And today, we are very proud to be showcasing two of our graduate student researchers, Dahai, Yue and Petra Rasmussen, who will be presenting their research along with Dr. Nunez Ponce, the Center Associate Director, on how the Affordable Care Act has changed healthcare access, particularly for the nation's low-income populations. They found that while the law improved healthcare in several categories for this group, the gains varied widely by race and ethnicity, and in some cases even widened the gap in healthcare. So before we bring up Dahai and Petra, I want to do a few housekeeping things. Number one, for our online viewers, if you have questions today for the researchers, please put them into the chat box that you see on your screen, and we will be having a Q&A session following their presentation. Also, today's seminar is going to be posted on our website on the newsroom page at the link that you see on your screen currently. And if you would like a copy of today's PowerPoint presentation, you can request one by emailing the address that is also on the screen. The previous slide, I apologize, it may have been a little out of order, was a preview of next month's webinar. Please mark your calendars for June 21st. We're going to be showcasing the work of Dr. Jim Krall, who is a Center Faculty Associate and the chair of the Public Health and Community Dentistry Department at UCLA School of Dentistry. Dr. Krall will be discussing a new project that he's leading called More LA Smiles, which just had its public launch this past Monday. The project aims to improve oral health for over 1 million children and youth in the LA area up to 20 years old who either have Medi-Cal or Denti-Cal coverage. So please join us on June 21st to hear more about that very exciting project. Now I would like to bring up Dr. Nunez Ponce to introduce her students and their work.
Thank you, Dr. Scheitler. Greetings and a warm hello from UCLA Center for Health Policy Research. I'm going to introduce two students from my home department, Health Policy and Management at the Fielding School of Public Health. Needless to say, I'm so thrilled that they will be presenting the results of a paper published in Health Services Research. They are also vital contributors to the center in addition to being students. Dahai Yue, the lead author of this study, is a candidate, a PhD candidate in health policy and management at the UCLA Fielding School of Public Health. He holds a master's degree in health economics from Peking University and also a degree in preventive medicine from Shandong University in China. At Peking University, he was in charge of managing a large project that evaluated the impacts of China's Healthy Cities Initiative at a nationwide scale. And here at the Center for Health Policy Research, he is multi-talented. He's worked on the California Health Interview Survey, which is a project that I lead here. He's also worked for the Health Economics and Evaluation Research section and has worked on a project we have with the University of the Philippines on conducting a survey, a population-based survey looking at non-communicable diseases, and has also helped in global teaching collaboratives. So we're very happy that he had enough time to actually lead this paper. And Petra is the same. So Petra Rasmussen is a doctoral student also in health policy and management at the UCLA Fielding School of Public Health. She works on a project called CalSim, which is housed here at the Center for Health Policy Research and in collaboration with UC Berkeley's Center on Labor. It's a microsimulation model that provides policy research and programming support, the evidence base for making good decisions, particularly for looking at covered California programs and expansion. Last year, she managed a team of graduate students who tracked attempts to repeal and replace, if you remember that fondly, that year, when it was, we never knew what was going to happen each day. And so we had a rapid response team that was led of course, by our center director, Dr. Jerry Kaminsky, and with Petra. Petra, and I see Jamie Godwin too. I think he was part of that team. And so Petra has a bachelor's degree in global health practices and policies from Duke University and a master's degree in health policy and management from Columbia University. So I'd like to welcome the two here with their presentation.
Okay, thank you very much for Dr. Ponce for the introduction, and welcome everyone for attending this seminar. So today we are going to talk about which low-income group did the ACA leave behind. And this study is from our recent paper published in Health Social Research Journal. This paper focuses on the racial ethnic differential effects of Medicaid expansion on healthcare access. So if we want to look more details, please check this paper. And we would like to thank the sponsorship from UCLA Graduate Summer Research Mentorship Program. And Dr. Ponce is my mentor for this paper. So the concept of this paper also came from the coursework we have in the PhD program. So we would like to thank our professors, Dr. Jack Needleman, Dr. James Masinko, and our teaching assistant, Dee Liang, Lauren Guest, and also our dear classmates for the feedback. So I will talk about the background and the method for this study, and then Petra will present the results and conclusions. After that, we'll open up to the questions. So the study motivation for this is there are so many studies show that Medicaid expansion has a lot of benefits for low-income people in terms of access to care. And also studies show that the racial ethnic disparities among non-elderly adults of all income have been narrowed, and the minority groups saw larger effects. Well, we believe that the narrowed disparities may be due to the fact that minority groups have larger proportions of low-income adults. So there is no study to look at those differential effects of Medicaid expansion among those eligible population. We think this is really important to examine the differential effects here, because to evaluate the policy returns of those a large-scale health reform policy and to understand how health disparities change after this expansion, and also to identify some unexpected consequences following this policy. So here is our research question. Did eligible populations in all racial and ethnic groups benefit equally from Medicaid expansion? So we hypothesize that yes, it is, but we expect some differential effects across those racial and ethnic groups. And the data we're using is a national representative data set. It's the public use file from the Center for Disease Prevention and Control. It's called BRFIS. It's a behavioral risk factor surveillance system. And we also abstract our state level number of primary physicians from state physician workforce data book. And the state level unemployment rate as a proxy for the economic change from the website of Bureau of Labor Statistics. So in the main analysis, we are using 2013 as our pre-ACA period and 2015 as our post-ACA period. So our primary outcome is health insurance coverage, which is a very popular measure to measure the access to care. And our secondary outcome include having personal doctors being unable to see doctors because of cost in the past 12 months, and they received a flu shot in the past 12 months as well. So let's take a look at our study design. We are applying a cross-experimental difference in difference study design, and there are 25 states expanded Medicaid. So we treated this as our treatment group. And we also have 21 non-expansive states. We use them as our comparison group. So to visualize this is we're treating the 2013 as pre, 2015 as post. Then we got those measures for the treatment and the comparison group. So we are treating the non-expansive states as our counterfactual group. Then based on this study design, we can identify the policy effect of Medicaid expansion. So our study population will be the adults. It's a non-elderly adults with income below 138% federal poverty line. these are the eligible population of Medicaid expansion. So our first step to analyze this data is a difference in difference analysis for all groups. So this is the statistical model setup. We have the interaction term here between the expansion dummy variable and the post dummy variable. So the gamma will identify the policy effect of Medicaid expansion. We can solve for a bunch of covariants identified from our conceptual framework. So this includes self-reported health, gender, race, age, education, and employment status, marital status, language, state fixed effects, number of children in household, number of adults in household, and also the state year unemployment rate and state year specific number of primary care physicians. So in our second step, we want to examine whether those effects are different across race and ethnic groups. So we did a subgroup analysis. So basically, we repeat our difference model for every single race and ethnic group. Then we got those estimates. This is the policy effect, gamma, for every single group. So we are applying the simply unrelated estimate test to test whether those effects across the groups are different. So here we are using multiple comparisons. I will talk later. We apply the Buffalo adjustment for the significant level. So we moved a step further to look at how those differential effects influence the disparities among those low-income groups. So here I will use an example for the health insurance coverage. We have the pre and the post. Then in the expansion group, we have the measure for non-Hispanic white and also the health insurance coverage for non-Hispanic black. So our measure of disparity is we use the insurance coverage risk in non-Hispanic white, then minus that value in the non-Hispanic black. So this is our measure for disparity. We did the same thing for the post period, and also in the non-expansion group, we have those measures as well. Okay, so because our research question here is to look at how disparity change and how that is associated with Medicaid expansion. So let's erase those numbers and only keep those disparity measures. Then we do another difference in difference analysis. Here, use non-expansion group as a counterfactual. We identify the effects on race and ethnic disparities. Okay, let's take another look at this really beautiful picture. So since we already did subgroup analysis for the non-Hispanic white, we got the different estimate for white. And also we have the subgroup analysis for black. Then we got this value as well. Then we want to calculate the difference for disparity. So it is very easy to look at what is the relationship between those three measures. So if you take the difference over the first two, they will be equivalent to the second. Okay, so in this paper, we are focusing on the difference between those estimators across racial and ethnic groups as our measure for the effects on the racial and ethnic disparities. Okay, so a couple of comments for our modeling. We used a linear model to fit those models. And also we did the Buffalo adjustment to correct the significant level of multiple comparisons. And we applied survey weights to become more national representative, and also to deal with the endogenous sampling. We also did multiple imputations because there are a couple of missing values there. So all analyses are conducted using data. To check the robustness check, we did a lot of sensitivity analysis. So those include differential sample definitions to deal with other policy issues there. For example, we did a sensitivity analysis only focusing on the non-elderly adults with income below 100 federal poverty line, and also another analysis to exclude those younger than 26 years old because there is a dependent coverage issue there. And we excluded those expanding Medicaid in 2015. So we also tried different model specifications try to use a three-way interaction there. So we have three tests for our parallel twin assumption, because this is the key assumption for difference in difference analysis. We did triple differences. We are using the senior people as the unaffected segments of this policy. And we visualize the pre-trend by pulling the longitudinal data set. And we also did a interrupted time series analysis based on quarterly data set. So now I will turn it to Petra to present the results and conclusions.
Thanks, Dahai. So I'm going to go through the main results of our study. So first we did some descriptive analyses of those individuals in the expansion and non-expansion states in 2013, which was before the implementation of the ACA, of the ACA's Medicaid expansion. So respondents in the expansion group were more likely to have health insurance and a personal doctor, and less likely to have unmet medical needs because of cost at baseline. But the demographic characteristics were overall very similar between these two groups. First, we can look at the adjusted difference in differences estimates for the impact of the Medicaid expansion on health insurance coverage. So among this population, which again is the low-income, non-elderly adults, we see that the Medicaid expansion was associated with a 7.1 percentage point increase in health insurance coverage overall. We then can look at Figure 2, which shows the effect of expansion on health insurance by race and ethnicity. The effects of the Medicaid expansion, as you can see, were weakest among those among Hispanics, and though they were strongest among non-white Hispanics. Figure 3 then shows the effect of the expansion on racial and ethnic disparities, and these numbers, as Dahai kind of explained earlier, are calculated by subtracting the effects shown in Figure 2 by race. So for example, if we want to get the white-black disparity, we would be looking at 11.02 minus 7.67, which gives us this 3.35 percentage point difference between whites and blacks in health insurance coverage. Overall, the expansion is associated with a 12.22 percentage point increase in insurance coverage between Hispanics and non-Hispanic whites. And this is the only statistically significant change in disparities, but the coverage gap for blacks and other races compared to whites increased by 3.35 and 8.52 percentage points, respectively. We also looked at the effects of the expansion on having a personal doctor. So in terms of this, overall, we found the expansion to be associated with a 6.63 percentage point increase in the probability of having a personal doctor. We then, again, stratified this by race and ethnicity and saw that both non-Hispanic whites and blacks had statistically significant increases in having a personal doctor. This was also seen for Hispanics and non-Hispanic other races, but these were not statistically significant changes. And the disparity between whites and blacks decreased by about 7 percentage points on this measure, although this was not statistically significant. Similarly, the findings were not statistically significant for white Hispanic or white other race disparities, but both of these saw, as I said previously, an increase in having a personal doctor. We also found that the expansion was associated with a 2.72 percentage point reduction in the probability of being unable to see doctors because of costs. And in this, only non-Hispanic whites had a statistically significant decrease when we stratified by race and ethnicity. Although not statistically significant, we saw a 7.69 percentage point decrease among non-Hispanic blacks and a 3.37 percentage point increase among Hispanics and a 2.58 percentage point decrease among other races. None of the effects on the disparities were statistically significant, although Hispanics had an almost 8 percentage point higher probability than whites in being unable to see doctors because of costs. Finally, we looked at the effects of the Medicaid expansion on receiving a flu shot, and overall, none of our findings here were statistically significant, and also all of these changes were fairly small in magnitude. So from our sensitivity analysis, we found that the different sample definitions and the survey-weighted regressions with three-way interactions all showed consistent estimates, as did the triple difference, which included the elderly population as a second control group. In conclusion, we'd state that the Medicaid expansion improved access to primary care, but differential effects were seen by racial and ethnic groups, resulting in mixed effects on disparities. Further research is really necessary to develop tailored policy tools for racial ethnic groups, and further work should be done to ensure that those trying to enroll non-white populations are able to do so that these groups can receive the full benefit of the ACA Medicaid expansion. We wanted to acknowledge several limitations in our study. So the question asked in Burfus about health insurance asked if respondents have any health insurance. So this does not distinguish between insurance types, which for our study means that we were not only looking at those enrolled in Medicaid. They could potentially have gained coverage through another source over this time period, or could have lost coverage through another source. The Burfus's household income measure is also categorical and did not directly correspond to federal poverty level amounts to calculate the Medicaid expansion eligibility. So this is a limitation. As well, the Burfus doesn't include an immigration status variable. This could influence our analyses, specifically for Hispanics, since immigrants who have been here for less than 5 years are often not eligible for Medicaid in many states, and of course, undocumented immigrants are not eligible as well. And although our tests showed that there were no severe parallel trend assumptions, and we had consistent results when we were controlling for our pre-trend differences between the two groups, we can't guarantee that the non-expansion states are a perfect substitute as a counterfactual for the expansion states. Finally, the treatment effect in this study is really only generalizable to that population who changed their insurance status during our study time. So at this point, I think we've got plenty of time for questions. And if we want to go back through and look at anything a little more closely or slowly, we'd be happy to do so.
We have several questions. So I'll go back and forth between the in-house audience and the online audience. So the first question, I don't really, let's see. This isn't going. Okay, the first question was, is the effect of Medicare expansion on access to care the difference between 2013 and 2015?
Sorry, could you say that one more time?
They wanted to know the time period. So.
Oh yeah. So the baseline time period is 2013, which is the year before the Medicaid expansion was implemented in most states, and 2015 is the year after the Medicaid expansion was implemented in most states.
Yeah, we're treating the 2014 as the transition time.
Anyone in the room? Anyone?
Can you speak to the importance of demonstrating the parallel trends assumption?
Yeah, thank you for asking. So the parallel trend.
Repeat it.
Could you speak to the importance? Oh, I'm Jamie Godwin. I'm a third-year PhD student in health policy and management, and also a graduate student researcher here at the center. And I was hoping you could speak to the importance of demonstrating the parallel trends assumption.
Okay. Thank you so much for asking. So the parallel trend assumption is really important for the difference in difference analysis. The main reason is we try to find a very good counterfactual method to identify the trend without the policy. So because we can only observe the outcome with policy, then we try to use the non-expansion group as a substitute for the counterfactual as without policy. So we have to make sure this is a very good substitute, very good proxy for the counterfactual. So that's why we need the parallel assumption. Basically, it means the trend for the expansion state, if without policy, will be exactly the same as the trend for the non-expansion state. So, and we did a couple of sensitivity analysis to check that. We got very consistent results. That's why we kind of very confident in our results.
Right, and as we saw, there were some differences between the two groups at baseline, but if the parallel trend assumption is upheld, then those trends could increase at the same rate. So that difference between these two groups, we want to make sure that that's not going to really influence the way that things change over time.
Okay, so from the online audience, why was a flu shot selected for a characteristic? Why not changes in chronic disease?
I would say that we chose flu shot in part because that is something that can be easily influenced by having health insurance coverage. So it's not something that we would necessarily need to see a long time period where you're covered, whereas chronic disease management would likely take a longer time period to see any substantial effects. So with flu shot, you either get it or you don't, and likely we could see in our conceptual framework a world in which you would get a flu shot at a higher rate, assuming you have health insurance coverage, than if you don't.
Yeah, we agree chronic disease is really important here, but we also include the flu shot because it's kind of a measure for preventive care, and this is another reason we are seeking to add flu shot here.
But for flu shots, usually sometimes people get them from different places, right? So the medical record may not be that complete, and so I would like to get your thoughts on that.
So this is a self-reported measure, so it's individuals who said that they received a flu shot in the last 12 months. So it's not a medical record issue. Oh, that's okay. But I do think that's a really good point. And partially, one of the reasons I think that we didn't see any significant effects is because you've already got individuals who are accessing this type of care through sources that may not require them to have health insurance.
Yeah.
From the in-house audience?
I just wanted to ask. Hi, Scout Campo. I'm a public administrative analyst here at the center. I just wanted to ask if you guys could speak on what happened to the Asian American population in your study.
Yeah, great. Thank you so much. So because we don't have enough sample size for the Asian Americans in the Profits data set, so we compared the all other racial and ethnic groups to you can see in our results there is a non-Hispanic others. So we include them in that group. So the Asian American account for about 24% of that group, and there is also Native Americans and Indiana there. Yeah, so we cannot distinguish them from the others group because of the sample size.
Just to follow up on that, is it so it includes multiracial? So your definitions of race are single race.
Oh well, in the other groups there is multiracial.
And the multiracial group.
Yeah, the multiracials are also good for the others. Thank you.
Okay, from online, why did Hispanic populations effectively have less coverage under the ACA?
So I think that is something that is a little bit unclear with the way that we're representing the results. So Dahai looked this up earlier, and actually, if you look at the unadjusted analysis, which are in the supplementary materials of the published article, we saw among Hispanics in the expansion group, health insurance coverage increased from 60% to 62%. And then among the non-expansion group, it increased from 41% to 44%. So that was a 2 percentage point increase in the expansion group, a 3 percentage point increase in the non-expansion group. So overall, the health insurance coverage rates are increasing. But when you actually look at the disparity between whites and Hispanics, that's where you get some of these differences, which show that Hispanics are just not making the same gains that non-Hispanic whites are at this point.
Yeah.
And of course, I would just want to say that within the non-expansion states, you wouldn't necessarily expect to see no gains among populations in health insurance coverage, in part because you've got this woodwork effect, right, of the ACA, where people who are already eligible for Medicaid are coming and gaining coverage because they've heard more about it recently, and they know that this expansion is happening. So even if the expansion isn't happening in their state, people are enrolling who are already eligible before the ACA.
Yeah.
I have a question about the equation. So here the YJ indicates the difference in difference estimates. Why don't you use, I'm not sure, why is not the primary outcome used here as the dependent variable?
So can you explain that again? It's why the outcome is not used here as the outcome?
So here in page 5, it writes the YJ indicates the difference in difference estimate. So my question is that why is not the primary outcome just the health insurance coverage or the personal doctors here, but the difference in difference estimate?
Are you talking about this slide? So the gamma here is the difference in difference estimate for the difference in difference. And the YIG here, because we have multiple outcomes, so we, like for the I, it's for the I individual, and J is this outcome.
Oh, sorry, I mistake the Y with the gamma.
Okay. Got it, thank you. Yeah, gamma is the DD estimate in this case.
From online, seems like the citizenship status aspect could seriously skew any analysis on changing disparity levels, since it prevents any material effect on increasing coverage for a specific subset of the Hispanic population.
I'd agree. I think that's one of the largest limitations of the study and of using this data is that we don't know individuals' immigration status. And since that is a key aspect of eligibility for Medicaid expansion or for Medicaid, then I think that is a real limitation. Yeah.
Yeah, and we also checked a couple of data sets. It's really hard to find a variable to identify, do you have undocumented membership at your household? So almost no data set have that question there. Although, yeah, CHIS as an ad. So CHIS has that variable, but we didn't use that because CHIS is about California. We can, yeah. So and so that's a very little limitation for the analysis, especially among the Hispanic groups.
And this is going to be an issue, of course, for surveys in general and self-reported surveys, and making sure that respondents are actually comfortable to be answering this question correctly or accurately. As we've seen in the debate that's currently going on with the census and adding a question specifically about your immigration status, it's just a sensitive topic to talk to people about sometimes.
Yeah.
Would there be a way to evaluate whether there were any significant changes in healthcare status for Hispanics versus other groups, taking these insurance coverage analyses into account?
So you mean, I guess, I'm assuming this individual is referring to, rather than just comparing them to whites. Yeah, that would be possible to do.
So the question is comparing the Hispanics with other groups. Yeah, that's definitely feasible, and we didn't check that in this paper because we are using the non-Hispanic white as the reference group. So we can definitely do that, but we don't have the results now. But
Somebody wanted to go back to the insurance data, but she doesn't say why, so I'm not quite sure what to do there.
We can just put it up there.
Questions? This is pretty much everything. I think that is all the questions we have from online. So, anyone in house? No.
I think one of the interesting questions that we've received from reporters that we've spoken to are whether or not these findings would generalize to California, and I think that's a really interesting question. For one, California expanded Medicaid early. So there could be actually some some kind of longer, farther down the line effects that we might see if we looked at this again in a couple of years that you would see in California. There's also perhaps a greater comfort with participating in public programs within California because of the atmosphere here. And we've got eligibility for Medicaid for immigrants who've been here for less than 5 years. So I think all of those things could combine to see a slightly different story in California, but I think it would be really interesting to look at.
Yeah, and another issue I want to point out is it's also from our reporter, is asking us, well, what should we do in the future based on your study? So as we all know, as from these people, we find Latinos benefit the least from Medicaid expansion. And as the immigration enforcement becomes more and more aggressive, that will definitely influence the Hispanics to enjoy in Medicaid expansion and even for a lot of public programs there. So I think the policymakers really think about that and how the immigration enforcement influence the Hispanics enjoying the public programs, because that will influence their health and the economies as well.
Yeah.
Yeah.
Yeah, it'll be interesting to track this over time, I think, for sure.
Question from Inez.
So I want to thank you for this study, but I was also co-author, so I feel a little awkward. Thank you for the study, but I do thank you for looking at national trends and seeing what's happening. So I'm just curious if you are aware of a study that was recently published that looked at actually non-expansion states. There were some groups that did better, the low income, and it might be because that the safety net clinics were bolstered. So not so much coverage, but safety net clinics. And so if you think of Texas as a non-expansion state with an increase in safety net clinics, that could be one of the reasons why. Like, it could be the woodwork effect, as Petra said, but it might also be that there might be some other health delivery incentives in place that is taking care of our populations.
Yeah, thank you for the comment. That's really important because as for Texas and another city like Florida, they did not expand Medicaid expansion, but they can still receive a lot of transfer from government for the uncompensated care in the safety net. The safety net is really a good resource for those uninsured, for the undocumented population. They go to the safety net, then they cannot pay sometimes, then the government still can pay them from the uncompensated care. But for states like in California, we expanded the Medicaid program here, but the undocumented population are not eligible for enrolling in this program, and also for the safety net, they probably lose a part of the funding from the federal and the state for the uncompensated care. So there is a gap for those undocumented population for the Medicaid expansion states. Yeah, so that's why we really need to think about how we move forward with the Medicaid expansion and also for the undocumented population.
Thank you. I think that's a really astute observation and conclusion for this talk. So thanks again for joining us at our Center for Health Policy Research Seminar Series. I thank the two presenters who covered such dense material in record time and for clearly conveying the rigorous methods that went into identification of the effects of disparities and of the ACA expansion, and for just expertly answering questions of what this means in terms of policies nationally for racial ethnic communities and possibly for California. So thank you for joining, and please join us next time. That I think AJ Scheitler talked about that. thank you. What is it? June 21st with Dr. Kroll. So thank you for joining.